Hi everyone, this video will give you a brief overview of Duchenne Muscular Dystrophy. So I'll start with some basic information. Duchenne Muscular Dystrophy is an X-linked recessive disorder, as you can see from this diagram here. And it means that women are normally carriers and men are the only ones affected by the condition. It is a rapidly progressive condition. It is caused by a defective dystrophin gene on the X chromosome, and a third of all cases are new mutations. Some basic pathophysiology. As I said earlier, it is due to a broken dystrophin encoding gene, and dystrophin normally works to strengthen muscle fibers and hold them together. And as you can see from this diagram here, it connects the actin of each muscle fiber to the basal lamina. With dysfunctional dystrophin, muscle degeneration occurs, and this means that all this healthy muscle tissue gets replaced with fat tissue, you can see around here, and there's a lot of muscle cell turnover because the fibers are not held together well or protected efficiently. Some of the key aspects of clinical presentation of a child with Duchenne muscular dystrophy: they will present very early at the age of 3 to 5 years old, and one of the signs will be waddling gait, which is partially due to the restricted hip extension. There will be something called a Gower sign, and it is characterized by this specific sequence of getting up from a lying position, and it is due to this muscle weakness, which requires this certain tripoding in order for the child to be able to get up. You will also see pseudo hypertrophy of calves, where the calf muscle tissue is replaced by fat tissue, giving the appearance of hypertrophy of the muscle. And lastly, you may also see scoliosis in children. A mnemonic for this is SPEWS, so scoliosis, pseudo hypertrophy, early childhood, waddling gait, and sign, Gower's sign. There's 3 key investigations that I would like to discuss. Firstly, the serum creatinine will be extremely raised, and I mean 50 to 100 times of the base level. Next, you can do something called genetic analysis, and you can find something like a gene deletion on the X chromosome, which would be the most prominent one, but you can also look for point mutations. And then lastly, if you're unsure with the genetic analysis, you can also perform a muscle biopsy, which will show an absence of dystrophin and show extensive replacement of muscle fibers by fat tissue, as you can see in this diagram. Some of the key management aspects: firstly, you can give prednisolone. It has been proven that a course of corticosteroids slows down the muscle fiber degradation. Secondly, physiotherapy and exercise is extremely important to try and keep muscles at their best, and to strengthen the person and to enable them to be mobile for as long as possible. Psychological support is necessary, especially if the child becomes wheelchair bound, and later on in the disease, respiratory assistance might be necessary. Some surgeries can also be performed, such as the Achilles tendon lengthening, which can improve mobility or extend it. However, in terms of prognosis, children are mostly wheelchair bound by the age of 12, and the current life expectancy is between 30 to 35 years. However, there are individuals who have lived beyond the age of 40. I know this is a very quick overview of the condition. If you have any questions, please leave them down in the comments. I hope you enjoyed. Thank you so much for watching.